My name is Geoff Underwood. I'm our Programme Director for Strategic OD and Transformation. And this is a talk about the work we've been doing with the Bath and North East Somerset, Swindon and Wiltshire Partnership, ICS, over the last year or so. I'm delighted to be joined by Richard Smale. Richard, do you want to introduce yourself?
Yeah, good afternoon, everyone. I'm Richard Smale, Director of Strategy and Transformation Designate for the Integrated Care Board in BSW. I've been working in the system a couple of years, so thank you for coming along.
So we're going to tell you a bit about the work we've been doing. First of all, Richard's going to introduce the system that he's part of the leadership team for, and then we'll take you through the work we've done to develop the strategic vision with all the people in BSW and with the public in BSW. We'll tell you a bit about the public engagement work we've done there and the care model that we've developed. And then we'll finish with Richard explaining a bit about how the model will be used in practice in the wild, in the ICS as it develops. So over to you, Richard.
Thanks, Geoff. So I'm going to start with a little bit about our health and care system. And like many in the country, the phrase "it's not a natural system" quite often gets used in our patch. So we're this geography here. So we've got a nice sticky out bit over here, which is the Bath and North East Somerset. We've got a massive area here, a lot of rural in Wiltshire, and we've got Swindon up on the top right. The system, all of our acute hospitals look outwards for their tertiary services in different directions. We don't have an economic hub in the middle of that system, so it's not like everyone goes to work in the centre or anything like that. We have obviously major cities in Bath and Swindon and Salisbury, but they're right on the outer edges of our system. So the system's always struggled a bit to sort of think, what is it and what was its identity? And when the sort of merger of the CCGs happened a couple of years ago, it was, why is this going to add value to us as a set of partners? So that was the work we sort of set about. A few dynamics about us. We've got a growing population, as many areas do have. We have a reasonable number of older people in that population, and quite startling forecasts as to how quickly that population is going to grow. We're quite an affluent area, particularly parts of Baines and Wiltshire, but Swindon's got some real pockets of deprivation, and there are other examples of deprivation in the other two counties, but if you look at the local authority ratings, generally we're a more affluent area, but really highly unequal. So, ridiculous wealth meets, real hardship within our system. So we've got inequalities, we just haven't got them at the same level and extent that certain other systems have. Very large geography, got a massive thing called Salisbury Plain in the middle of it. So, we don't have great transport networks, we don't have great public transport, things like that. So lots of sort of challenges for our population that, they're not unique to us. There are other systems like us, but they're there. And our three acutes are right on the outer edge of our system. So again, an interesting question about, well, how can they work together? What could they do differently? When do they collaborate? So it was lovely when Victor gave his speech earlier this morning, he referenced the work those hospitals had done in tackling children's waiting lists together and actually treating people. So there are examples where we work across it, but it's not the easiest geography. There's no motorways going across the middle of our patch to join things up. So I'll probably do the next slide, and then I will hand on to Geoff. So this is a bit of our story. As with everyone else, there was a publication of the Integrated Health document back in 2020. That set out our vision, and of course that set out our vision and where we were going just before COVID kind of came along and hit us. So we had the challenge of all of that. And what we realised fairly quickly was we had a document, but we didn't really have ownership of that document. We didn't have partners saying, we're clear what this means. So it had been written, it served the test of putting in a document, but it really didn't have the ownership and the sort of acknowledgement of partners. So what we went into was looking at what we currently had across our system, and Geoff, I'll leave you to cover those in more detail, about what already existed within our system and what did we want to do differently. And this is a piece of work we're going to talk through today, and we refer to it as our care model. We set about, with the current partners, really having a conversation about how do we think health and care will work. And at first we went very deep, and realised we wouldn't get there, so we sort of went a bit more high level, and the work Geoff did helped us with that. And then, where we've got to now is a sort of narrative that we'll talk through, which says this is what we're aiming for. And we're trying to use that narrative as a constant reminder when we're having a conversation about urgent care or estates or workforce, that these are the things that we're true to, and making sure that everything we do aligns back to that. Now, we don't always get that right. We still produce documents that pretend what we've done never exists, but we are getting there. We're working as a partnership to get there. So I'll let Geoff take you through the model, and we'll come back to the themes of what we've done.
Thanks, Richard. So we started off the piece of work on this in Bath and North East Somerset, and actually I started working with BSW when there was a project going on supported by our friends and colleagues in KPMG, where we developed this model in Bath and North East Somerset to describe the future there. And once this had been developed, we took this on tour around the rest of the system, and I went to present this in Swindon and in Wiltshire, and where part of the feedback was, well, this looks great, but we've got one like this. And so we discovered we had these 3 models of care across the 3 places in BSW, and then quickly moved on to a piece of work to try and bring these together to create one overarching strategic vision for the whole ICS. The first thing we did was to look at the 3 models that we had in the 3 places and see what people liked about them, what people thought was relevant to take forward into the ICS. So in this Bath and North East Somerset model, what people liked about this was the idea about having some sort of coordination system in the middle, that it's built around coordinating things for people, and people quite like the themes of this. So they quite like the idea of having a bunch of stuff around prevention and population health management, stuff around enhancing out-of-hospital care, about strengthening community services, and about building hospitals of the future. That box there went down with people really well, because a lot of the conversations people were having were about what should we not be doing in hospital, what do we need to shift out? And we were talking a lot about what we didn't want hospitals to be doing in the future, rather than what's the role of specialist centres in the future. So we shifted onto discussion. People like that idea about describing the future positively rather than what we didn't want. But on the flip side, looking at this model, it was quite technical. There's quite a lot going on, and people find it quite hard to sort of look at and absorb. So we took notes from this one. This was the model that Swindon had developed about 4 years before. So this was from about 2017-18. Again, it's quite technical, quite sort of schematic. What people in Swindon really liked about this was the little apples that you'll notice around the model, which was what the intention of that was to show that prevention should be part of everything in the future, and people really wanted to retain that idea. It's got coordination in the middle, again, with the clinical hub, so something in the centre about coordinating things for people. Something that people liked on this model was the idea of technology wrapping around everything and joining everything together. And there's a sense here trying to describe how things flowed around the system as well. There were some things missing from this, so there's no mention of population health management on this model, for example, just because it was developed 4 or 5 years ago when people weren't talking about that. And then this was the work that Wiltshire had done. So what people really liked about this model was that there's a person in the centre rather than a service. And they liked the model was themed around what a person might need depending on what's going on with their health and care at the time. So a section about supporting self-care when you're well, about proactive care and support perhaps for people living with long-term conditions, and then those 2 sections on the bottom about what you might need when you're recovering from ill health, or what you might need in an emergency. And there's also quite a bit more on this one about the sort of teams that people might need and the other sort of enabling things that we might need to actually deliver some of this. So we learned from those 3 models, and then we just started drafting a potential future model, and this was our first go. And the process we really followed with this was to do a draft, take it out to talk to people for a couple of weeks, and do another draft, and keep going until we got to something that people could agree with. So we kind of threw everything at the first version. We started by trying to build it around a community rather than around an individual or around a coordination service, and we were trying to reflect diversity in the community and make sure anybody looking at this could see themselves or see their family or see their friends on this model, or see themselves represented. We like the idea about the technology coordination thing. So this halo of this glowing halo around the outside is intended to represent kind of data joining things up, and the people in the model and the buildings have got these glowing devices that was intending to sort of show digital joining things up. It was important that we included the integrated care systems mission in the work. So that's this statement here: working together to empower people to lead their best life. And also in BSW's literature, there's a lot of talk about the life course. So starting well, living well, aging well. People really wanted that represented, so we've got that in there. We got loads of feedback on this, lots of constructive criticism about the language and the sort of density of it. So we moved on to another draft where we tried to bring in the idea of the themes. So those other previous versions we were looking at all in some way kind of themed what they were talking about. So we introduced a few themes in this version, a theme around improving health and well-being, around coordination, not just coordinating things for people, but coordinating across the ICS. So, one of the benefits of being an integrated care system should be that we're able to coordinate things across different sectors and different organisations and across all of those boundaries. There was something about things being more local, which we tried to reflect with a theme there, and something about facilities of the future. So taking that idea about hospital of the future, but broadening it out. So we're not just talking about hospitals, but what facilities in a broader sense do we need for the future? So we got plenty of feedback on this one, and I think it was in one of the meetings discussing this that someone in Swindon shared a model from Camden where they had the idea of a sort of a person or a community in the centre with these concentric rings of services coming out from it. So we moved on to this draft. We kind of knocked this up to see what people would think. And people like this, like the idea of the community in the centre, and the different kind of rings of support coming out. One of the pieces of feedback from one of the LMC chairs, I think, was this makes it look like the specialist centres ring is the biggest ring, and it's dominating still. And that was not the intention. So there was a bit of feedback on trying to balance out the real estate in this and emphasise that the community should be the place where most things are happening. So we fiddled with that a bit. And people actually said, it's great having the community in the middle, but you've lost the person in the centre. We should have, if we're going to have proper personalised care in the future, we really ought to be representing that clearly in the model. So I think from this one, we moved on to our version 1. So this was version 1 of the BSW care model, where we've got the person in the centre, living in a healthier community, which is supported by effective joined-up local teams. And then when people need it, they're referred to local specialist services, and then there are specialist centres out there when they need them. But the idea is things should be available for them, much more locally, and you should be able to access much more from home or where you live. So that's where we got to about October last year, and then we started a phase of public engagement on this. So we ran a 6-week public engagement in November and December last year. Bearing in mind at that time there was still a lot of COVID restriction happening. Most of the engagement was online, although we did do some in-person events. And I think that was sometime during the engagement was when Omicron started rearing its head and people were a bit more concerned again. But despite that, we managed to reach over 1,400 people through our engagement events. We ran 65 different events, which varied from specific events set up to engage with particular groups to getting it on the agenda for existing forums around BSW, and we had some just open online events that anyone could sign up to. So through those 65 events, we heard from over 1,400 people, and we had over 900 people complete our online survey. So there was a ton of feedback on this. Our colleague Martha Cox did the diligent work during December over Christmas and New Year of writing all of that up and producing a report so that we could really hear what we'd learned from the public and then update the model to reflect what we'd heard. And this is what people told us. So broadly speaking, people agreed with what we were trying to do. And what was really, some of the key learning points for me from this were how interested people were to hear about this, how much they agreed with the broad direction, but how quickly they wanted to get to, so how are you going to do it? Most people asked, how are you going to pay for this? And most people asked, where are you going to find the people to do this? Because people are really aware of the workforce shortages in health and care. People are struggling to get appointments with their GP or to find an NHS dentist. So we had loads of questions about that. But there was strong agreement with the principals, that strong agreement about having coordinators who make sure things join up for people, that we work together across health and care and other sectors, that things should be more available close to where you live, particularly specialist services. People agreed personalised care is important, and building up communities by working on their strengths. So, as Richard said, the Bath, Swindon and Wiltshire system, or Bain's Swindon and Wiltshire system, is there's a lot of variation in that system. So it's what we were trying to do with this is create a vision that everybody could sign up to and then still deliver differently locally, because the local requirements of a population really vary across the system. These were some of the other key themes. So a lot of people raised concerns about digital potential exclusion. In the first draft of the model, we had a box that said we're going to use digital by default, which was supposed to be a kind of positive message about how we wanted to get the best out of technology, but people interpreted that as you'll never see your GP again, you'll only be able to have a video consultation. And so we got loads of feedback about that and changed it. People were really concerned about mental health provision, but also this point about vulnerable clients and access to services. Lots of people had questions about what does this mean for me or my condition or my family or where I live. So people really wanted to get into the detail. As I've said, a lot of people asked about where are you going to get the people and where are you going to get the money, and people were really interested in how we join up with voluntary community and social enterprise sector, but also the unpaid volunteer carers and people who are involved in providing care for people in their family or their friends, and how do we keep people engaged in this conversation now that we've gone out to talk to them. So having heard all of that, we then provided an update to the model, this is from February, so we're on to, BSW is now on to version 1.1. So I'll just talk you through this and then hand back over to Richard to tell you about what happens next, how this is actually going to be used. So this is the overarching graphic of the model. From what we heard from people, it was really important to emphasise this is a model that's intended to be for the whole population of BSW. So throughout we got questions like, well, does this include services for children? Does this include mental health? Yes, it absolutely does. The intention is this is for the whole population. It's for the whole life course. So it's intended to include starting well in life, living well, aging well, also end-of-life care and dying well, which a lot of people wanted to make sure was specifically included and stated in a model. And it's about all aspects of health and care, so physical and mental health, social care, and also tackling the wider determinants of health and prevention and helping people live healthier lives. The model is essentially about these 5 things. So certainly the way I think about it is that if BSW ICS nails it, then it's about nailing these 5 things. So at the centre of the model is personalised care. Everybody in BSW should experience a personalised approach, no matter how they're interacting with health and care services. So if you're a relatively healthy person and you want some advice on how to choose better things to eat or to access exercise, you can access that in a way that works for you, in a format that works for you, in a method that works for you, right through to if you're living with multiple long-term conditions and you've got your own personalised budget and access to a named team that knows you and is helping you to develop your care plan, that's personalised care for you. But we want personalised care to be almost the foundation of all of this. Everybody in BSW should be living in a healthier community. So the idea of that is that wherever you're living in the system, where you live helps you to live a healthier life. So whether that is by having, the things that we directly commission, things like good access to GPs and dentists, for example, through to, the place where you live, it's easier to ride the bike to work because we've sorted traffic out and there are cycle lanes, or there's good public transport options, or if you want to access education at any point in your life, that's easy to do where you live. If you want to go for a walk to improve your well-being, there are nice green spaces that you can get to and they're safe to walk in. If you want to buy fresh fruit and veg, you can do that on your high street, and it's not just a run of betting shops and chip shops. So the healthier communities bit, that's where that's the main sort of prevention part of the model, I think, and where I think there's loads of opportunity to join up across things that we do in healthcare, but things that our colleagues in local authorities do. For example, planning transport, planning health and leisure services, planning education. Those healthier communities should be supported by joined up local teams. And one change that we made in this version is that we put the healthier communities, the personalised care and the joined up local teams all in the same circle to show that those joined up local teams should be really embedded in those healthier communities. And the joined up local teams bit, that those the two parts of that are really intentional. So joined up, as in no matter who's paying your wages, you can work together in that team. So your laptops will be able to, you can use your laptop in each other's buildings, you can share data, it's easy to email each other. We get rid of all those organisational boundaries. And the local part being that the teams are really set up and tailored for the local populations they're serving. So the intention is these joined up local teams would be at the neighbourhood level, which will be really different in central Trowbridge to central Bath, for example, or rural Wiltshire or central Swindon. Then when you need access to specialist services, there are much more local specialist services available. So you may be able to access things from home through virtual consultations. You may be able to access things closer to where you live at a community diagnostic centre or an outpatient clinic at your GP practice or something like that. And then when you need to go to a specialist centre, they're there for you. But because of these other parts of the model, in the future, the specialist centres should be able to focus on the things that only they can do. I can think of lots of NHS examples of that because that's my background, but the specialist centres part is not just about acute trust, it's about specialist centres run by the local authority, it's about the hospices in BSW that are specialist centres run by voluntary community and social enterprise sector, so that is supposed to be a broad and inclusive category. And at this stage, Richard, I hand back to you to talk about what happens next.
Thanks, Geoff. Geoff told a story there about a lot of toing and froing and a lot of interaction, and the image is great, but the conversation and the journey people went on was almost more important than the graphic for many. But that said, we're a population of 900,000 people, and we've touched a fraction of them in that process, whether they're staff or members of the population. So lots still to do. This is a growing story that we want to talk about and tell. And one of the things I always broke Geoff's heart with was, we'll never finish this, or never be complete. So that it's that ethos that this will evolve with us. But what we are now trying to do is use this imagery, this concept, the way we've spoken about it, to really inform the other things we're doing. So whether that's our work on the workforce and really beginning to say, well, yeah, we could really worry about training that type of people or those things that we've always done, or really get into the space of what would that multidisciplinary team in the community look like? What would use of the voluntary sector and partners really be within this model? So how we work with the workforce, the type of technology we have. So, we've got, Catherine Dampney was around earlier talking to her. There's limits on the capital funding that are there. What we choose to buy, what we choose to spend, how we, make use of people's mobile phones, all those sorts of things are really key questions. But we want to link it back to what did we say in the model that is relevant. The facilities we've got, again, big questions given our geography about what are the right facilities, how do we create environments. So we had a problem in our system where we had GP practices who needed more space, so they were asking the community midwives to move out. So the very concept of integrated working was actually failing because we didn't have space and geographic. So we need to really use this concept to hold ourselves to account, to say, is it all right for partners to make, in a way, unilateral decisions that move us further away from the goal we want to be in? And then, the point I made at the start, this is not the end. This is a continuing evolution of a conversation, and it will continue to evolve. Do you want to just click us on? So for the project planners in the room, we are working out what are the interventions, what are the actions that we are doing. So, all of us are under pressure now to do virtual wards and create virtual wards. Well, what do they mean in the context of this model? How do we want our primary care to work? And we're really getting into that so that we're beginning to align our technology, our workforce, our estates, our clinical design programs to really connect in with this and put the focus, a lot of the focus around ICSs has been on the organisational and the change associated with that. We're trying to really put it back on, no, this is about the care, the way it operates, and that wider determinants of health that Geoff alluded to. So genuinely, if the biggest health risk is the condition of housing in some of our poor areas, well, let's, as partners, have that conversation. So that's what we're trying to do, turn what's a nice concept, a glossy image, into some very tangible delivery. So we haven't delivered this yet, but that's our sort of aspiration and goal. And it's allowing us to have a joined up conversation that we're heading in the right direction together, I think. So I think that's it. So that was all we were going to say. Do you want to set up the questions?
Yeah, that's our talk. So if there are any questions in the audience, we'd be happy to take them now, or we're happy to mill around and have a conversation afterwards. There is one question there. David.
Hi, thanks. Very accomplished presentation. David Kane, I'm Chairman of the Pain Relief Foundation. An observation, on the virtual wards, I'd urge you to be really careful that we don't repeat the experience of the 80s with convalescent beds, but that's just me being old, not needing the beds, of course. My comment is about where is the investment with social enterprise and where is a potential opportunity for partnerships with those sorts of ventures. I can see that needs to be explained. Thank you.
So I think it's a good question, and again, we haven't nailed it fully, but what I would say the model is doing, one of the things it does is it redresses the power imbalance in the system. It enables all the partners to say, hold on, we're a player in this, and we can see how our role works and what we contribute. So we're trying to create environments where partners who previously might have been little heard voices can really come in and say, look, you know that bit in the middle of that image, we can help with that. And again, it's not a quick fix. We've had years where we've invited partners to the table and then talked to them about NHS issues like waiting lists or A&E 4-hour waits. We've got to change that narrative. So some of the conversations Geoff and I have had is, could we start every meeting from the centre of the model and work out, if you structured an agenda and actually do some really practical things that just show the desire to listen and hear different things. We've had a couple of examples in our system with COVID around the setting up of community hubs and the voluntary sector and the role they did, and they moved overnight, didn't they? Was our experience. They set up things. We overcame all the governance concerns that we would normally have. How dare we send somebody round to somebody's house to check if they need some shopping if we haven't vetted them 12 times? All that stuff kind of got stepped away. So I think we're trying to work with them in the spirit that entrepreneurial, creative spirit that existed, but in a way that is, safe. And that's the trick. But it's a long way to go. But the idea of the model is you can describe yourself and the contribution you can make in a way that fits within a wider piece. Does that answer your question, David?
Oh, Douglas, you want to ask a question?
I think I'm standing too close. What would you like the Integrated Care Board to do in order to empower what you're trying to get done?
Good question. Stories are really important, aren't they? And unless we keep telling the story, we'll forget about it. And 6 months from now, nobody will talk about this, and we'll be doing the next Emperor's New Clothes idea. So I think the first thing is that sort of ownership. So I've been in the system a couple of years. I will carry on in the system. Most of my new colleagues at the ICB level will be new. So one of the things we've got to do is give a talk like this to colleagues and say, we want you to come in and own this. We don't mind if you refine and improve it. We don't want you to ignore it. So I think there's something about that educational bit. We had an example the other day, I haven't broken this news to Geoff yet, where one of our partners produced a paper for their governors that didn't mention this and spoke about clinical strategy. So I think we have to go back. We don't have to sit in judgment on that, but we have to go back and we have to provoke the conversation that says, okay, are we being true to, are we being consistent with? And we have to back it with things like investment decisions. What's the different investment decision we'll make around digital that we wouldn't have made in the past because all we'd have had in front of us was the business case written by the team that were able to afford a project manager to write a business case. So I think it's those type of things. It's small little things that practically make it real. But we've got to keep telling the story. We've got to keep talking about it, and having the courage to do that, I think, is really key. What's great now, is I'll go often into other meetings around our system, and people will tell me why the care model is important or what they're trying to do. And that's great. We're creating that ownership, but it's still superficial given the number of people in our system. So we have to keep working away at that. Does that answer you?
So my second question is about qualitative data that you're hoping to collect from populations.
So the question for everyone's benefit was about the qualitative data we're hoping to collect from populations. We're still in the foothills of quantitative data, or the right quantitative data, I would say, and the qualitative bit is still coming. So for us, we're coming. If you remember my image at the start, we had 3 very disparate IT functions in the commissioning bodies, and we had completely separate digital functions in the acutes and the other providers. We are revisiting that. We're looking at the infrastructure that's there, so that we're trying to completely rewrite how we gather and think about data. I think there's a lot of work we could do. We've got University of Bath in our patch. We need to learn from people who do this stuff well and know how to do it, and plug it in. And simple things like we're looking at shared decision making as a model, and how you can use simple data capture techniques to say, did we ask you what matters to you, rather than what's the matter to you, with you? Did we ask you about your goals and your outcomes? So I think we're getting there with that. Sometimes when you speak to clinicians, they reassure you that every clinician does that as routine. I think experience would suggest it's a bit more hit and miss. So I think it's gathering those things in lots of ways, and finding a systemic way of being able to talk about it at the ICB, if that makes sense. So,
I should mention it's one of my other colleagues in SCW. It's leading that shared decision-making pilot in our digital transformation team, if anybody wants to know about that. Are there any other questions? Otherwise, thank you all for coming and listening, and we'd be really happy to chat with you after this. Thanks very much.